Welcome everyone to the September 2016 IRCP session. We're pleased today to have Walter Tavares from the Toronto area to do a presentation for us. He actually did a session at our face-to-face meeting in Saskatoon, but we didn't have enough time and he had a ton of good information, so we asked him to do a full session today. So Walter, take it away.
Thank you, Gary. So as Gary mentioned, my name is Walter Tavares. I'm a paramedic with York Region Paramedic Services, and I'll describe what that is in just a minute because it'll have some relevance to the study we're going to share with you. I'm also a researcher with the University of Toronto at a place called the Wilson Center with postgraduate medical education, and also with McMaster University in the Division of Emergency Medicine there. My primary role, in addition to being a paramedic, is that of a researcher, a practice researcher, but also education researcher. And the study we're going to share with you today, as the title suggests or says, is Improving Patient Access, Care, and Transportation by Paramedics. This is one phase of a multi-phase program of research that's being led by York Region Paramedic Services. And so this study here helped pave the way for some of the practice changes that we're considering in that area. And so the idea here is to share this presentation with you, and what I'm hoping for selfishly is that there is a very critical look at this work so that hopefully you can challenge some of the things that we've put out here that we've come up with. So that we can strengthen our program of research. The other thing I think that might be helpful is that there might be, this might serve as a useful example in terms of how we're determining practice changes in our context. And so you'll see here in a minute that we're focusing specifically in the 911 system or in the emergency system, and we're trying to establish or determine or support at least whatever practice changes we try to implement at that service model. Whatever changes we make there are supported by evidence. So we recognize that this type of work is being done in many places around the world. And so local context will be important. I'll describe that here for you in a minute. But whether it's applicable to your context or not, I would be very interested to hear. So to get started, I just want to acknowledge first some of the people that were involved in the studies. Ian Drennan is a PhD researcher in our area up in Ontario, Canada. He's just about to finish his PhD. Ian's a paramedic. Mike Avenel is a paramedic as well, who helped us with the study. Chris Spearn is acting deputy chief up in York Region Paramedic Services. Kelly Van Diepen is a physician and researcher at McMaster University. Matt Mercury is an epidemiologist and researcher at McMaster University, and Noah Barrett is the chief for York Region Paramedic Services. So before I begin, I don't have any conflicts of interest to disclose, and research ethics was provided by these 4 different organizations: the university, where my affiliation was primarily at the time of the study, and then these 3 hospitals by which we retrieved data from. So I'll share that with you in a minute. And of course, the study was supported by York Region Paramedic Services. So just to give you some context for those who might not be aware, so we're located near Toronto, so in Ontario, Canada. So that red section there of that map, that yellow section is Canada, the red being Ontario, and if we zoom in a little further, there's the map of Ontario, and that star is where Toronto is, which would probably be the most common landmark. And then in this map, you see Toronto, the borders of Toronto being down in the center of the picture by the lake there. And just above Toronto is York Region Paramedic Services, or the regional municipality of York. In terms of land, it's larger than Toronto, but in terms of population, it isn't. It's a population of about 1.1 million. It includes a mix of urban, suburban, and rural, residential, and industrial and commercial properties. And this service gets somewhere between 80 and 100,000 calls per year, with 26 to 36 ambulances in its system. 24 hours a day with 21 response stations spread out across that region. It employs about 490 paramedics now, 145 of those are part-time. And I think about 35 or 40% of that staff is at the advanced care or ENTP level. It's dispatched using something called IRCP, computer-aided dispatch. It's not something I'll be talking about today, but just if that provides relevant context for people. And it's within its borders, it has 3 regional hospitals by which anyone who calls 911 gets transported to one of those 3 hospitals. And there are, of course, other hospitals outside the border of York Region that paramedics will transport to, but there's basically 3 main ones sitting within its boundaries. York Region Paramedic Services uses an electronic record system, and their care is governed. Care actually in all of Ontario is governed by the Ontario Ministry of Health and Long-Term Care Services, Emergency Health Services Branch, and by various base hospitals. And for York, it's a base hospital that's referred to as Central East Pre-Hospital Care Program. Provides the medical oversight for this particular region. So it may not be too unlike a lot of different places in that it's not purely urban or purely suburban or dense populations, although it does have that in some areas. There's a good mix of demographics in this particular region. So, and given that context, so giving you a sense of where we are and the service that we're working with, it sits within a healthcare system that is experiencing system pressures like everywhere else. We know that in many places around the world, there are these increasing healthcare needs and this either decreasing or stable availability of healthcare services, or at the very least, this challenge in terms of what we consider demands versus supply and access. And so that tension exists, and again, I'm aware that this particular group is very familiar with that tension and has come up with many, many solutions by which to address this tension through paramedic services. And so that same reality exists here in Ontario. There's quite a bit of pressure to find ways of being more efficient, more effective, and doing so under considerable restraint in almost all areas of the healthcare system. Now, one of the places that we're seeing quite a bit of pressure, or at least serves as an example of pressure in other areas, particularly for patients who are experiencing emergencies or crises, as they would perceive them to be, is in ED use or misuse. And so this serves for a lot of us as an indicator of this problem of this healthcare tension between what exists in terms of resources and the demands that might be there. And so the public in our area has become very reliant on the emergency departments. And it starts to speak a little bit to the availability of other resources, although we know from the literature that increasing some of those other resources like primary healthcare settings or access doesn't seem to mitigate this issue. And the issue of ED use or misuse is problematic in that it leads to crowding, of course, and that crowding we know can lead to negative clinical outcomes. And so this is a real big target for our healthcare system to try to address and find ways of solving. The other thing that EDs are being used for in our context is as an admission pathway. So there's many primary care settings that will divert to emergency departments as a way of admitting patients rather than admitting them directly. And so you get this significant flow into that healthcare system. So that only serves as an indicator, as I mentioned, of the tension that we have. And that tension exists in many other places that would be relevant to us, like primary care. So the idea of this ED use or misuse issue, there have been a number of solutions that have come up been proposed and implemented as a way of dealing with these system pressures, and not just in our area, but in many places around the world. So, for example, trying to implement some financial incentives for patients not to use ED or public education in terms of saying, here's what we need to be able to do, or here's when you should be using an emergency department and perhaps when not, and maybe even some other resources that might be available in the province. And so both of those strategies really haven't had an impact on this issue and the negative clinical outcomes that go along with it. And then the other part of it, other strategies include this idea of increasing the availability of primary care or ambulatory care. And in the previous example, in terms of incentives and education, the strategy there was really about reducing misuse. And in these examples of increasing resources and capacity in other areas, it really is an effort to try to reduce need. And many of the community paramedicine programs that are out there work in this area where they're trying to increase capacity and resources outside of the 911 system, outside of the emergency department, to try to reduce the need for ED use and diversion. So another strategy, another solution that's come up, again, to try to reduce this issue or to try to help with the system pressure would be to try to increase care coordination and this idea of complex managed care. And the idea here is that through care coordination and managed care, that these patients we should be able to detect these patients a little sooner and then care for them in more timely ways, and then that would reduce the need for ED use, hopefully. So all these strategies have been implemented in various places to varying degrees of success. And one of the areas that we're seeing some success, obviously, is between the emergency department and primary care and ambulatory care settings. And that relationship, strengthening that relationship, is certainly starting to have an impact. And that was the last example I gave you in terms of this integrated care, this idea of integrated to managed care. And so that relationship is having some impact. And one of the strategies that's included there that systems are trying to improve on is to have emergency departments speak to primary and ambulatory care settings, so the primary healthcare physicians. And so again, I'm speaking about the Ontario context here, and I'll be interested to hear at the end here if these examples are being used, and if so, with what kind of success in other settings. And so the public use and need continues to rise, certainly in our area. There's no signs of decline. The anticipated needs are continually growing. And so much like many of you have already thought of, this idea of including paramedic services in this system of care, in this integrated managed care system, is a way of affecting change and a way of affecting efficiency in a system that is in need of it. And so in our system, paramedics in the 911 system at least, like many places, are targeting emergency or urgent events and might be underservicing patients in other ways. And so the idea was to try to come up with a way of contribute to this mitigation of the problem, of this tension between healthcare resources and demand. And so we felt like it was a capacity issue, an access issue, and an issue where paramedics were actually contributing to the problem rather than mitigating the problem, mainly because they were underservicing patients for a large bulk of the ones that they were seeing. So again, this work is, we know that this type of work has been going on in many places around the world, and what we were interested in was, in this context, how do we understand the scope of practice changes that might be necessary to address this issue, structured as I've talked about. And as a reminder, this was a program of research where we're looking to eventually make scope of practice changes, again, to the 911 system, and so this step was necessary. So that's somewhat of the background and rationale for the study. And the research question that we came up with early on was, of patients transported to an ED by paramedic services, specifically following 911 activation, what's the course of clinical care disposition and most responsible diagnosis for this patient? We wanted to know, this gives us, as I'm sure you can put together, this gives us a sense of how well the paramedic system is responding to the care needs of the patients they interact with based on those who contact 911. So those who activate emergency services, how well are they being cared for? And so having a look at that data and the discrepancy that might exist there starts to give us a sense of where the gaps might be and then how to correct them. But it was important to try to factor in issues around safety as well, and so I'll get to that in just a second. Before I go into the next research question here, there are a couple. It will be important, if you're going to follow along here, you might want a pen and paper because there'll be some things that I'll ask you to keep in mind as we go through some of the presentation here. So there's a bunch of data I'm going to show you here in a minute that will require you to reference back to earlier slides, and so you just might want to make note of that. So this was our first research question. Of patients transported to ED by paramedic services, what was their clinical course essentially? And most responsible diagnosis to give us a sense of how patients were being treated and then what interventions might we want to include as a result. The second research question was to ask what additional clinical services provided by paramedics, again, in this 911 model would result in the greatest access, care, and intelligent transportation for patients encountered during emergent or urgent events. So the piece that we have no control over is the activation of the 911 system. This is a public-initiated process. Certainly, many groups are thinking about how to intervene in that process, either at the dispatch level or by providing people other options to call. But for those who contact 911, once that process begins, that's a public-initiated process that we have no control over. And so it's very important to target, to have a look at that population, if you will, to see what we can do better with. So we looked for additional services. So in this sense, we were interested in looking at what, if we included additional services, what impact would that have on the overall system for these patients that call 911. Whoops. So again, this was really an effort to try to not understand these differences, but to try to address these issues of increasing healthcare needs and the availability of healthcare services with the long-term goal of building capacity and access for patients, specifically for those who are experiencing events, a crisis of some kind. So the study design was fairly simple. It was a retrospective cross-sectional descriptive study with a model simulation that followed that part. This is the part that I think might serve as a model for some others who are interested in this kind of research or interested in establishing practice changes and are looking for ways of supporting practice changes. That this might serve as a model, for you to use in your settings. And if people were to replicate this type of study, and we were to come up with similar findings throughout, as has been done in other healthcare settings, it might really start to help us look at this on a broader level and a broader scope. So again, a retrospective cross-sectional study, descriptive study, and then there's a model simulation that follows. So essentially 2 parts. I've already taken you through the setting, so I won't spend any time here. The simple, perhaps oversimplified study design is here. So we looked at patients who had contacted 911 and were transported to an emergency department, and for which we had healthcare records for, electronic patient care records for. We were interested specifically in that population. We were then interested in, we then calculated a sample of 3,000 health records that we would look at to help give us some estimations. Of those 3,000 health records, that was across 3 different emergency departments. And if you remember, I mentioned early on that there were 3 regional hospitals within this service. We then looked at our primary outcomes, which I'll get to in a second, and then as I mentioned briefly already, we looked at simulating a number of models and what impact that would have on healthcare system. So when we were looking at the 911 system, or the patients who contacted 911 and were transported to an ED, we were looking specifically for people who were within these regional boundaries for our ED purposes. We didn't look at any kids. It was only patients over the age of 18. They had to have contacted 911, and they must have been transported to one of the 3 regional hospitals. We have a triage system in Canada called the Canadian Triage Acuity System, or CTAS, It's basically, you can think of it as a way of ranking priority in terms of need for ED services. It goes from 1 to 5, 1 being extremely severe, dead or close to dead, 2 being below that, and then all the way down to 5, which would be sort of your walking wounded, if you will, or those with very, very minor complaints. So we took everything that wasn't a CTAS 1, which is very clear that those patients need an emergency department. And then we made sure that they had a matching hospital record, and then we didn't include anybody that was part of an interfacility transport or that was part of another study or bypass. So in this area, there are regional bypass protocols for STEMIs, strokes, traumas, that sort of thing. And so none of those patients were included either. Give you a sense of what we were looking at. So of those 3,000 hospitals, those 3,000 health records that we extracted now from the EMS side, so we started the data collection at that side, collected 3,000 health records from there. Once we had those 3,000 patients, before we concluded those 3,000 patients, we stratified by hospital and by CTAS. In other words, we wanted to make sure that our sample population that was being included in the study was reflective of the population at large, which turned out to be about 77,000 records or so. And so we wanted to make sure that we captured a reasonable amount of patients for each hospital, which represented different demographics. And we also wanted to make sure that we represented different CTAS, which represents different priorities. So we stratified according to those conditions, and we compared them to the larger population before closing out the 3,000 patients we would follow. So our primary outcomes, there were many, there were 15 in total outcomes that we were interested in. The ones that that I'm going to share with you here today were their admission or disposition, the most responsible diagnosis, the interventions that they received in hospital, and the diagnostics that they received. As I mentioned, there were a number of others, but we're just going to talk about those. We then took that information, we took this information of admission, disposition, interventions, diagnostics, etc., and then used that to create some models. So these are simulated models of EMS systems, and said if we had these services in place, these interventions, diagnostics, etc., what impact would that have on the need for additional ED services? And again, these are simulated models before we actually make practice changes. So the analysis plan was straightforward in retrospect, but at the time it took us some time to work through. We came up first with a classification system, which I'll share with you in just a second here. We searched first and foremost for an existing classification and found some in the ambulatory care literature, but nothing in our literature that I think fit this context. And so it's not a complicated or any sort of advanced classification system, but it's just a way to help us think about certain patient groups. We then explored the interventions and diagnostics that existed within those different classifications, and this is the part where you'll want to follow along here in just a minute. So we created classification systems, then we looked at interventions and diagnostics. We looked at that by group, so the classification system creating actually more than 4 groups, and I'll show you that in a second. And then we established an index, and so this index was calculated by looking at the frequency associated with admission, as well as another metric, frequency as well as association with admission. So those two metrics were then combined to establish an index for us to help us rank different groups and patient types, etc. And I'll show you that here in a second. And then we also looked for the most responsible diagnosis, and again, we used the same index strategy. So this is again looking at the frequency in which these events occur in this 3,000 patients and the association with admission. And so we use that same sort of index strategy for this most responsible diagnosis to have a sense of what it would tell us. So again, our strategy was to look at paramedic services and what kind of models, what kind of service or practice models could we put in our system to try to contribute to mitigating the problem, mainly through building access and capacity in the 911 system. This, of course, took place along with looks at other systems in terms of what they're including in their scope of practice changes. So to start with our results, we had 77,000 records that we could go through we had 55. This is basically not entire. York does more than 70. They do between 80 and 100,000 calls per year. These were 77,000 records that were available to us based on some of our criteria. After we cleaned those, we got down to 55,000 and cleaned them again. And so this cleaning is essentially looking for duplicates and also looking for inclusion and exclusion criteria. And so eventually you start to whittle that down. We got to about 32,000 patients, and from there we randomly selected 3,000 patients of that population. There were then we made sure that we had 1,000 records from each of the hospitals that we were working with, and then ensured that the CTEST distribution was similar to our larger population. In that data, we had a mean age of 57 for the patients that were included, for the 3,000 patients that were included. And 1,600 of them had an ECP on site. So this system, York Region Paramedic Services, has structured their service delivery to include either advanced care with a primary care paramedic or 2 primary care paramedics. And I think that's fairly common language, but if not, I can provide clarification there.
Walter, could you speak just a little bit louder?
Sure.
A little closer to your microphone.
Yep, sorry about that. There are, I think, 41 communities in York Region Paramedic Services, and our 3,000 patients represented 23 of those communities. Okay, so here now are some of the results. So the first thing I'd ask you to pay attention to are the groupings. So this is a classification system that I was describing earlier. So you'll notice here that where it says group, there are 10 groups that were established. Those groups were derived from whether or not they received interventions, whether or not they received diagnostics, and whether or not they were admitted or not. You take all of that in addition to those who died and those who left against medical advice, and you end up with about 10 different groups. So the first thing we did was create these groupings using these categories and placed patients into these groups. We were less concerned, and I don't think I have it here. We were less concerned with the groups 5 through 10. All these patients were essentially admitted. And so we gave the benefit of the doubt here and said if they were admitted, they probably needed ED services, and so we're not going to focus on those patients. There's obviously a limitation to that. There may be some that didn't need ED services but simply needed admission. There's a number of combinations that could come up there, but for the purposes of our study, we said, look, these patients were admitted. Let's just assume they needed the emergency department as well. So what we were interested in, what's bolded here, are groups 1 through 4. So group 1 being those who received no interventions whatsoever. These are ED interventions after paramedic transport. No ED interventions, no diagnostics, and are not admitted. This obviously serves as the patient population that most clearly doesn't need to be in an emergency department. And then you have the other groups, which are interventions. Group 2 doesn't receive any interventions, receives some diagnostics, it doesn't receive, and is not admitted. You can think of that as a rule-out category where they might have gone through some tests to look for things, maybe found nothing, or maybe even did find something but didn't require intervention and were not admitted, were safe enough to be discharged from the ED. And then you have a group of patients who received some sort of intervention but no diagnostics and also were not admitted. And so these are the patients where you could say that there might have been some sort of correction or treatment or fixing that happens in the ED, but not again requiring any diagnostics and certainly not admitted. And then you have the patients who are received interventions and diagnostics and are not admitted. And so these obviously tend to be a little sicker. These patients need some more things. Now, within each group, there's quite a variety of patient types that you can have in that, and I'll get to that in a second. So in looking at just that group, here's some of the data that we received. So of in the 4 groups, of all the patients in our group, 1,954 patients of the 3,000, or 65% of patients are not admitted. We interpret that to mean that there's some degree of opportunity here for paramedic services to intervene. And then you can see for yourself the distribution of patients. So group 1 being 3.6% of patients don't receive any diagnostics interventions, and 20% only receive some sort of rule-out criteria, and then group 4 having the bulk of the patients who receive some sort of intervention or diagnostic. So this data alone doesn't tell us much other than saying that there's an opportunity perhaps in the 65% of patients to perhaps have some sort of impact. So this is what I'll ask you to keep in mind is these groupings, so groups 1 through 4, and then what each group refers to in terms of interventions and diagnostics. You can remember that none of them are admitted, but we'll have to keep in mind the intervention and diagnostic combinations. The next set of data to show you is these top 10 patient types. So there's a clinical classification system that we use that's based out of the U.S. That's used to basically organize international international classification disease codes. So these are codes that physicians that are attached to diagnoses and procedures and many other things, and so they're very, very granular. And when they're that granular, it makes it difficult to derive any sort of meaningful outcomes. And so what this group in the U.S. has done, and a number of researchers have since used, is this CCS grouping, or this clinical classification system, to group similar ICD codes. And so rather than do the work yourself in trying to identify what how these ICD codes come together, this group has done that for us. I should mention, though, that for the 3,000 patients, when we went into the hospital to extract their data, it was all at the raw ICD code. In other words, we captured the granularity first, and then assembled them into these groupings to come up with the top 10 patient types. So these are the top 10 patient types listed there for the 3,000 patients that are not admitted. So they're only focusing on those patients that are not admitted. And you can see for yourself again what the top 10 conditions are. Where you start to see something like abdo pain, for example, could be very, very broad. And so within that category, there's a number of different conditions that fall under abdo pain. And that exists for all of them. Some are as few as 2 or 3 conditions that fall within the category. Some might be 10 or more. And so it's important to look at this patient type list with the understanding that there's more information below the label. So where it says nonspecific chest pain, there are a number of conditions that fall under that. And where it says other injuries, conditions due to external causes, same thing, there's a number of conditions that fall under that. And so for the sake of time, I'm just presenting the large groupings here, but certainly that data will be made available. So then we looked at the frequency. So these are the numbers of times of the 3,000 patients who were not admitted. So this is 1,954 patients. Of those patients, what is the frequency of conditions? So nonspecific chest pain, for example, falling in number 2 in terms of we saw these 145 times out of 1,954 patients. So there's this number 2. Now, the ranking next to it here of where you see here 0.95, 0.89, and so on. This is, again, now looking at the total patient population. So now if you look at all 3,000 patients that are admitted, not admitted, what is their ratio of discharge directly from ED? And so you see that other injuries, conditions due to external causes has a discharge rate of 0.95, nonspecific chest pain, 0.89, and so forth and so on. So you see something like syncope has a discharge directly of 0.77. And what that tells you is that there's a proportion of patients, more so than, say, for example, 0.89 nonspecific chest pain, that are being admitted. And so the lower this number is, the higher the risk exists when you're trying to make the scope of practice changes. And so ideally you want something that's at 100 here in this category, and there certainly are conditions that fall at 100, but they're so infrequent that it doesn't make sense to have scope of practice changes for that patient population. Likewise, you might have something that's so frequent, that's more frequent perhaps than these things here, although we didn't find that in our study, but you might find it in other contexts, that it's not worth paying attention as well. So you want something that's very, very frequent and has a high rate of discharge directly from ER. That creates your index and a way of ranking these things. And so you take all of that, you use the ranking, and this is how we ranked our top 10 conditions. So if you looked at just frequency, there might have been a different order set, and if you looked at just discharge, it might have been a different order set. When you combine these two things, you start to get your index, and that gets you your rank. The next is the top 10 patient types, again, using that grouping, that clinical classification system, and the list of patient types I just identified for you based on index. And now you can look at them by group assignment. And so what you'll find here is for all of these patients here, none of them fall into group 1. In other words, all of them at least receive some sort of, not all of them, but you can look at those bolded in group 2, where there's only a few of them that only sit in group 2, whereas the bulk of them sit in group 4. But very few of them are in group 3, which was the intervention group, 2 was a diagnostic group, and 1 was none of the above. And so group 4, so this just simply tells you that the majority of these patients that are being transported are getting some sort of intervention and diagnostic. There are a couple that are just purely diagnostics. So then you take all that information and you start to create models. So you take all the interventions and diagnostics that exist that were captured as part of that abstraction. So in other words, when we followed any one of those 3,000 patients, after they were transported to eMERGE, we followed them, transported to eMERGE by a paramedic. We followed them in eMERGE, and we followed their clinical discourse, or their clinical course. We looked at the interventions, diagnostics, and their admission status. For those, and then we looked at all of those diagnostics and interventions, and again went through a ranking procedure for that, and then came up with, so you can rank interventions and diagnostics in the same way in terms of frequency, let's say. So you can do that empirically, but you can also do it clinically. In other words, you look for groupings of interventions that make sense, clinically make sense. And so there's multiple ways to do this. We're reporting 12 different models here, but in fact, there might be, I think we looked at about 50 or 60 different models. There might be hundreds that you could possibly look at. But what we're reporting here are those that have the largest impact on reducing the need for additional clinical services. So in other words, if you provided paramedics with these diagnostics, what result would that have on the system? We tried to extrapolate that through simulations. And I'll talk about the strengths and weaknesses of doing that in a little bit. So the first is we just looked at diagnostics only. So if we said, if we looked at diagnostics only, we came up with a number of models. I'm presenting only 4 here. Diagnostics only, even still, if you added to the scope of practice these diagnostics that are listed there, you'll have significant gains, a percentage change of 369%. So a huge gain from 108 patients to 507 patients affected, where you could start to say that perhaps these patients don't require ED services and can be managed in the community by paramedic services. And one of the things I should mention here is we didn't give ourselves any sort of boundaries. We did think a little bit about feasibility, but we even then we still made sure that we didn't give ourselves any boundaries. We assumed anything was possible early on, and then started to peel away based on what we thought was feasible and practical in our system, and then put those into the various models to see what kind of difference we would have. So if you gave just diagnostics, you would have a significant gain in their performance, in the performance of the system in terms of not requiring ED services. So there are some things here that still might catch your attention. For example, X-ray, whether or not that's feasible in systems, and troponin, something like that requires serial investigation, and so that might, again, raise a flag for you to say this is not something that's feasible in our system. And that would be fine, and if you remove those two, what eventually happens is this number comes down, and so you start to change the model a little bit. The next one, so this is just an example, and we only listed 10 here, but of course you could run the exact same models with 5 conditions or 5 diagnostics, 2 diagnostics, 12 diagnostics. It really is anything, and the system that we built allows us to create any model we want, plug in any sort of diagnostics and interventions we want, and then spits out what kind of potential impact it has on service planning. So the next is if you looked at just interventions, and you see here we're not having the exact same gain. So while we did have a gain in introducing these these interventions, it wasn't as big a gain as the diagnostics were. And so that's already one lesson learned in terms of system structures, is what you need to build is not so much what you're doing. It tends to be more this ruling out process, a safely ruling out process, or so it seems. And so interventions alone had an impact, but not as much as might be worth it when you start to think about the resources you would need to put in order to build these interventions in. When you consider the two together, so that the best model for diagnostics and the best model for interventions, and combine them, which wasn't entirely the most frequent, but the ones that had the biggest impact on the number of patients we can move into group 1, which again was those patients who may not require any further ED services. And so as you start to add in these systems, you see the gains can be significant, up to over 500% gains. So moving from 108 patients to 691 patients in this group of 3,000. If you extrapolate that out, that 35% gain, as you extrapolate that out, then you can imagine what the numbers could be in various systems. And again, these are simulated models that would need to be tested further in actual practice models. So then that's one way to look at it. Another way to look at it might be to say, if we were looking at examples of models on some patient types. So in this case, I just picked 3. I picked other injuries, conditions due to external causes, non-specific chest pain, and abdo pain. Remembering that abdo pain had a problematic index in that a lot of these patients get admitted. But anyways, if you look at this and you start to look again at those different models, so models 1 through 4 being diagnostics only, 5 through 8 being interventions only, and 9 through 12 being interventions and diagnostics, you start to see where the gains might be or might not be. And so where the largest gains seem to be in models 10 or 12, and earlier on I just presented to you model 12, which included these diagnostics and interventions. Model 10, which I didn't present, is just a variation of that with slightly different combinations that for the sake of efficiency, I didn't present all models here, but that information is also available. But what you start to see here is the impact on specific patient types. And so you go through all these permutations in various models, and you try to come up with the system that would have the most impact on the patient types that you think are either most frequent, least risky to intervene with. So you go through that.
Walter, could you try to be a little louder? Yeah.
Yep, sorry. So anyways, you go through all these permutations and all these examples, and you try to come up with the model that best impacts the patient types that you think are most feasible to target and the least risky. And so you could do this many, many different ways, and what I'm presenting here is just a few of those models on a few patient types that might be of interest. So model 10 and 12, and for the sake of this presentation, I just showed you what model 12 is. Model 10 is not too far from here, but they're not too far from what you see here, but there are some variations that I could share with you after this. So taking all of that information, which is a lot, again, our interest was to have some sort of impact on the system. We were interested in building capacity and access. We're trying to build practice changes and scope of practice changes in our system, and so we wanted to be able to identify how best to go about that. That again was the goal, and the idea being that we think by doing so, we might be able to help deal with some of the strain that exists within the healthcare system in our area. And so again, we're hoping to build paramedic services or integrate paramedic services into emergency department and primary care settings where we think that there's an opportunity to work with those other two in a way that requires some shifting of clinical services to the paramedics to be able to support both those systems. And so when you look at all this, there's certainly an opportunity, and I think everyone here knows that. there's an opportunity with 65% not being admitted, there's certainly an opportunity to do something. In our system, if we extrapolate these numbers out, it works out to be about 35,000 patients that we may have an impact on. Of course, that's most likely an overestimation, but even still, there's a large number of patients that we could safely affect. There is absolutely still some risk. And so this data, these discharge rates that I'm showing here, are a reminder only to the earlier table, which showed things like a discharge rate of 0.77 suggests a risky patient type to target. So if you're trying to build systems, EMS systems, paramedic systems, going after these high discharge rates or these patients that have a riskier index is probably not the wisest first step. So you tend to focus on these that have high discharge rates early, and then as you build your system, you can start to work towards those ones that have a bit more risk associated with them. It's also not wise to just go purely for the most frequent, because those patients don't necessarily represent admission status, and so you have to consider both admission status and frequency when making these decisions about system changes. So interventions and diagnostics alone are insufficient, but in combination they have real power to make some significant gains in the system. And of course, the obvious caveat to all of that is that none of this is purely intervention and diagnostic based. There's obviously a huge degree of clinical reasoning that goes along with the inclusion of any interventions and diagnostics. So if you're going to include these things, then of course you want to be able to factor in any sort of efforts that are necessary to achieve the required clinical reasoning to do so, or safety mechanisms to support that. The diagnostics matter most, so if you are looking for quick wins, the quick wins are in the diagnostics. Again, the caveat being the clinical reasoning and interpreting those diagnostics and knowing when to do them. But that's the quick win. The interventions seem to have less of an impact, but when you combine these two things, it has the most significant gains. But of course, this has implications for your training and resources. Sorry, let me just move on to the next one here. And so patient types also matter. And so when you're thinking about what system you're going to build or what kind of practice changes to consider, you're also going to focus in on patient types. And the relationship between the diagnostics that are built in and the patient types and how they're affecting the patient types that are of interest and that are the least risk or that come with a reasonable degree of risk needs to be part of the equation. Some had very minimal impact, so regardless of the interventions and diagnostics we built in, it didn't really affect our abdopain group. So when you combine the fact that diagnostics and interventions that seem to help a large population of patients don't help the abdopain patients, plus there's there's more risk associated with abdo patients, those tend to be the ones that you don't want to, at least early on, build practice changes for. And then of course there are others that have much more impact or much more significant. There's another thing that hasn't been talked about and wasn't studied in this particular study, but there is certainly this culture issue. This culture of practice matters. This certainly in our area, the culture is to transport everyone or almost everyone or many patients, and shifting that culture would take some time or at least some consideration. And so that wasn't a factor here. We just assumed everyone would buy in, and that may not necessarily be true. But we also know that many are being transported unnecessarily as well as a result of this data. And so this culture of transport requires some attention, and some existing skill set alone could potentially already have an impact on without doing anything else if they were permitted to not transport more often. So as far as limitations for this study, this again is a bit aspirational, the study is. We removed any boundaries from ourselves in terms of saying, we won't include this intervention or that intervention for reason X. We just allowed anything to be possible and looked at all the different models given that. And we were realistic in that at times we removed some of those things that we felt were not feasible, but that was only one model of many. And so that has some limitations attached to it. Of course, this is one region. I was as explicit as I could be about the region at the start, so that people can make inferences about whether or not that region reflects their region and whether or not these kinds of practice changes would be reasonable in their settings. And as I mentioned earlier, multiple models are possible, multiple approaches are possible. And so I think, again, if anything, if the data is not generalizable to your context, I hope at least that the model is, and you can take that process and replicate it in your settings. And then, of course, share that data and see if we're coming up with similar things. These are, of course, simulations that can't possibly consider all possible factors, and so both over and underestimations are possible. I would probably lean on the side of overestimations. We're probably overestimating the results. So those very high numbers that I showed you earlier, as I said, might be overestimates. But even still, I think even if we took a portion of that, there'd be significant gains in the system in terms of building capacity and access for patients during crisis. And of course, there's plenty of feasibility limitations. We included X-rays, for example, in one of our models, and in some settings that might not be a problem. In others, it may be. And so that has to be considered when you look at all these different models. So our goal, again, is to try to shift some of the services from emergency departments over to paramedic services as a way of building capacity and access. And it really was about trying to identify scope of practice changes that would be most supported by the evidence in our system and the culture that surrounds our system. And so consumption of healthcare, as I said earlier, is not likely to decline. And so we need to think about how we can build capacity, and this being one way of creating that pathway. The idea is to correct this underservicing of populations, and then, of course, to try to find ways of integrating services and try and find, can patients be shifted in different directions as a result of the services and capacity that might exist elsewhere. And then stop contributing and begin mitigating is one of our large goals, and we think that this current system is contributing much more than it's mitigating, and so there's certainly an opportunity to do there. The other thing we didn't look at, or didn't discuss here, I should say, that we did look at was ambulatory care sensitive conditions. So we did similar analyses for ambulatory care sensitive conditions specifically. Rather than open it up to all conditions, we looked specifically for those and started to think about how we could target that. The difference when you do it that way is when you look at all patients, you're really focusing in on the emergency department patient to a visit. And the ambulatory care sensitive starts to put a primary care or ambulatory care lens on it. And so it's a different way of looking at very similar data to help make informed decisions regarding practice changes. So I think with that, I'll thank you. And if we have the opportunity, I guess I'll take some questions.
All right, great. Thanks, Walter. I'll unmute the lines here in just a minute, and we'll let you ask questions if you'd like to. We'll also post a recording of the session on the Paramedic Foundation's YouTube channel. There'll be a link on the IRCP website in our archive to go directly to that. So I'll unmute the lines and see if there are questions.
The conference has been unmuted.
Any questions for Walter?
Well, you're letting me off the hook easy. That's good. If there is anything, my contact information, anything that comes up after today, my contact information is there. And I would certainly welcome any challenges or critiques to this, because it's something we're certainly putting a lot of time and energy into and thinking about, and are just about at the stage of making practice changes. And so your thoughts would be helpful, whether it's redundant, important, add something the model would work in other places, etc.
Yeah, hi, Walter. It's David Long from Brisbane in Australia. Can you hear me okay?
Okay.
Hi. I very much enjoyed that. This is my first webinar. Actually, unfortunately, I couldn't follow it online. I don't know if everyone else is finding this, but Windows 10 is putting out updates, and it seems to crash the computer for at least 2 hours. Just some of those figures again. Did I hear correctly? You found 65% of patients were directly discharged from the ED?
That's correct.
Yeah, that's impressive numbers, and you suspect that may be slightly overinflated, as I understand it. Just also, have you published yet this study, or you're thinking of publishing sometime soon?
So, to answer the last question first, we've submitted it for publication. We're just waiting to hear back. The 65% is of patients transported by paramedics, 65% of them are not admitted. What was probably an overestimation were the models that we built to predict system changes or to predict the number of patients that wouldn't require ED services. So those numbers were very high, and so I'm just taking a conservative stance on those results rather than suggesting we're going to change the world here.
Yeah. Fantastic.
So
thank you very much.
Once it is made available for publication, then I'll make sure it gets distributed.
No, please. No, it's fascinating research, and it's providing, I guess, more detailed information than I've certainly found in the literature about where paramedics might be able to make an impact. So, no, thank you for that.
Yeah, I think if anything, the model might be useful to other places. And so, if nothing else, if you did that, which I think is very feasible now that it's built, I think we'd be happy to share it. It wouldn't be a problem.
Any other questions? Well, Walter, I was really fascinated by your grouping stuff when you talked about this at IRCP, but we only gave you 20 minutes, so I'm glad you got a chance to do the full thing today. That was very helpful for me. And
I was just going to say, sorry to interrupt you. What I was going to say about that grouping is it's important for this group to know there are two groupings, essentially. The grouping based on intervention diagnostics and admission status, so that's one grouping that might be relevant to other people. The other is the groupings by patient types, and those are also important. And I just want to remind people that you really need to look at the detail within each of those to make informed decisions. And so it's not reported here, but it will be included in our publication.
All right. Well, thanks, everybody, for joining us. I'm not sure if we're going to have a session in October or not. I'm still waiting to hear back from a speaker, but we'll get back with you as soon as we have another session set up. So thanks for participating.